4 different types of lacerations, or degrees of laceration as they're referred to. So, first degree, the laceration extends through the skin and vaginal mucous membrane, but not the underlying fascia and muscle. So a laceration is like a spontaneous tear. So this is not episiotomy, so these are spontaneous tears. First degree, it extends through the skin and the vaginal mucous membrane, but not the underlying fascia and muscle. Second degree laceration extends through the fascia and muscle of the perineum, but not into the anal sphincter. A third degree, the laceration involves the external anal sphincter. And a fourth degree, the laceration extends completely through the rectal mucosa, disrupting both the external and internal anal sphincter. Of course, it's important for these to be repaired correctly for future, for the mother in the future. It is common for females to have small lacerations on the labia minora and the sides of the urethra and the clitoris. And sometimes in delivery you'll hear these just kind of referred to as skid marks. So basically they're just little spontaneous tears. They're not enough that they require any kind of repair with suturing. They just heal on their own. Third and fourth degree lacerations must be repaired for the mother to retain fecal continence in the future. And then, like I said, those simple injuries heal on their own without repair. Here's a picture of the 2 different kinds of episiotomy. The first kind, the kind we're more familiar with, is the median or midline. And the second, it's to the side, to the left, is the mediolateral. The mediolateral can be cut to the left or to the right, either one. So the midline episiotomy is the most common. It's very effective, easily repaired very easily, and it's less painful. There's higher incidence of 3rd and 4th degree lacerations when you have a midline episiotomy. So what that means is the provider cuts a midline episiotomy, but as the baby's delivering, it extends that episiotomy into a 3rd or 4th degree laceration. Now, you can cut an episiotomy to a 3rd or 4th degree, but typically it's cut to about a 2nd degree episiotomy, and then you potentially have those lacerations. The mediolateral episiotomy is used more for operative births, and operative births would include forceps and vacuum deliveries. They're used to prevent a 4th degree laceration, so if you have a patient with a very, very short perineum, it's best to do a mediolateral episiotomy so you don't end up with a 4th degree. There are greater blood loss, and it is more painful. So what we know is episiotomy should be avoided unless necessary. Tears are often smaller than episiotomy and heal quicker with less pain. So spontaneous lacerations are usually better than an episiotomy unless it's just absolutely necessary. You can also get vaginal and urethral lacerations. They're often a result of forceps, rapid fetal descent, or precipitous birth, so the baby just delivers very, very fast, and there's not that counter pressure from the provider, and the baby just delivers real fast and causes some spontaneous lacerations. These are usually not too bad and can heal on their own. Sometimes they do need a few extra sutures. Cervical injuries occur when the cervix retracts over the fetal head during delivery, and this can be if a mom is pushing before she's 10 centimeters. Most cervical injuries are shallow and heal on their own. However, if you have an extensive cervical laceration, it can affect future pregnancies. Okay, now we're going to talk about the 3rd stage of labor, and the 3rd stage of labor is birth of the baby until the placenta is expelled. It's usually the shortest stage of labor. Usually the placenta is expelled within 10 to 15 minutes after the birth. If it hangs on for greater than 30 minutes, that's usually problematic. Some of the signs are a sudden gush of dark blood from the introitus, apparent lengthening of the umbilical cord, and a feeling of vaginal fullness. So about 10 or 15 minutes after the baby's born. So sometimes the baby is born, the provider does any kind of repair, sutures, lacerations, or episiotomy, and then delivers the placenta. Sometimes they wait until the placenta delivers before they do their repair. But some of the signs, again, are a sudden gush of dark blood from the introitus, lengthening of the umbilical cord. So the umbilical cord was kind of tight, and all of a sudden it gets a little bit longer, and that's because the placenta is separating on the inside, and a feeling of vaginal fullness. After delivery, the provider, and a lot of times the nurses get really good at this too, examining the placenta to make sure there's nothing that's left, that it came out completely. And then as far as the disposal, usually it's put in formalin and sent down to pathology. Depends on the hospital. Some of them are just thrown away in the red bag trash if there are no indications of IUGR or calcifications in the placenta. You have to take into consideration cultural preferences. Some cultures take the placenta home, some bury it, some dry it, and some even eat it. So the placental separation, active management decreases postpartum hemorrhage, and active management includes administering oxytocin, clamping and cutting the cord within 3 minutes after birth, applying gentle traction until separation. So as they're standing there, they're applying just a little traction on the cord, not enough to, basically rip out the placenta or to cause any problems with the uterus, but just a little gentle traction or pulling until it's separated. The patient pushes to expel the placenta, just like they pushed with the baby, except this takes much less effort. When the placenta comes out, there are two sides. There's the shiny fetal side and the dark, roughened maternal surface. So when you do the examination, you can see two sides. The shiny and smooth side is the membranes where the baby was, and then the other side looks like kind of chunks of meat, and that's where it was attached in the uterus, and that's the part where lochia comes from. It's basically an open wound inside the uterus that has to heal, so that's where lochia comes from. On page 467 in your book, box 1913 has nursing care during the third stage of labor. This diagram shows the third stage of labor. For A, you can see the placenta begins to separate. You have some retroplacental bleeding, so you can see the placenta is separating right here, and in the middle where it's separating, there'll be some bleeding behind the placenta until it completely separates. That's the retroplacental bleeding. The uterus changes from a discoid to a globular shape. In B, the placenta completely separates and enters the lower uterine segment. The uterus still has that globular shape. C, the placenta enters the vagina. The cord lengthens and you see an increase in bleeding. In D, you have expulsion of the placenta. And it's just important, usually the provider afterwards will do a manual exam of the uterus to make sure there are not any retained placental parts that can impede healing after delivery and normal involution. Where the uterus returns to normal, it can cause infection and bleeding. On page 469 in your book, there's box 1914, shows assessment during the fourth stage of labor. So the care management, fourth stage of labor is that first 1 to 2 hours after birth. So from placenta delivery until 1 to 2 hours after birth is the fourth stage. You want to assess the maternal physical status, and during this time, the mother's body is returning to her pre-pregnancy status. Signs of potential problems include excessive blood loss and alterations in vital signs and consciousness. Hemorrhage is the most dangerous potential complication during the 4th stage. Care of the new mother. She's extremely hungry and thirsty, so usually you don't want to feed them real heavy food until a good 2 hours after delivery, just to make sure everything's going to go okay. There's always a chance that if they're bleeding too much, that they could return to surgery. But anyway, so you don't keep them NPO, but you don't want them to go out and eat pizza and cheeseburgers, everything they've been craving during labor. They are very thirsty, so you definitely want to give them something to drink. This is also the time where they bond with their baby. Then they rest, and sometimes they'll need, not sometimes, they'll always need assistance with their shower, but that's care of the mother. As far as care of the family, during this stage, you want to initiate breastfeeding to take advantage of the infant's alert state and stimulate production of oxytocin. So right after delivery, during the first hour or so, babies are very alert. They're crying, their eyes are open, their sucking reflex when they're skin to skin, you can see that. So you want to initiate breastfeeding as soon as possible after delivery before the baby gets sleepy and will not be successful with breastfeeding. That breastfeeding stimulates the production of oxytocin, which helps the uterus contract after delivery to decrease bleeding. So there's benefits to both the mother and the baby for the breastfeeding. Family newborn relationships. Reactions vary from excitement to disappointment. So, most families are just very excited, very tearful, and celebrating. For instance, if the baby is not the sex that they wanted or has something wrong with it, sometimes they're disappointed. Be aware of cultural norms on how certain cultures respond differently. Warning signs that the bonding is not occurring like it should. You could have the mother be passive or hostile reactions to the newborn. Disappointment with their gender or appearance. They don't have eye contact, and very limited interaction with the baby, and couples limited interaction with each other. Siblings are normally very excited and are encouraged to hold the baby and talk about the baby. And here's just a picture of looks like a new brother loving on his new sibling. So if your patient has had a C-section or regional anesthesia, they require special attention during the recovery period. So the post-anesthesia recovery unit, you want to monitor in addition to everything else, but their activity. So if they've had an epidural, you want to monitor as their feeling comes back and they're able to move their legs and their feet, their respirations, their blood pressure, level of consciousness, and their color. And in addition, you want to also have the normal postpartum assessment. So you're going to be assessing their fundus and their lochia, their incision if they had a C-section, their perineum if they had a vaginal delivery, if they had, for swelling, and making sure the sutures are intact. And then here are your key points for this chapter. And here's the question. So after an emergency birth, the nurse encourages a woman to breastfeed her newborn. The primary purpose of this activity is to A, facilitate maternal newborn interaction, B, stimulate the uterus to contract, C, prevent neonatal hypoglycemia, and D, initiate the lactation cycle. We know, so the correct answer is B. A is incorrect because breastfeeding definitely facilitates the maternal newborn interaction, but it's not the primary reason that women are encouraged to breastfeed immediately after birth. B is correct because stimulation of the nipples through breastfeeding releases oxytocin and prevents maternal hemorrhage. C is incorrect. The primary intervention for preventing neonatal hypoglycemia is thermoregulation. D is incorrect because it's important to initiate the lactation cycle, but stimulating the uterus to contract to prevent bleeding is the primary reason.